Hi folks, we're at it again. Today we're talking about the communication planning process in more specifics than we have in the past. Each week we'll be building on more tangible, specific angles around this process and then weaving in some advocacy along the way. So, all too often we end up functioning in emergency mode. True probably in life in lots of ways also, but in terms of public health responses and health communication specifically, we don't necessarily move from a grounded, intentional space. We move in reaction to the things around us. So the process we're talking about is moving from an ideal position rather than a panicked, frantic, running around in circles kind of example. Just to rehash some of the things we've talked about before, health communication planning ideally is evidence-based, research-driven, and grounded truly in the needs of the environment of the key audiences. I'm not going to apologize for hammering that one home. A communication plan can advance the mission of an organization, it can engage others in an issue, support health and social change, encourage action and partnership, or all of the above, frankly, depending on what the community, the stakeholders, and you in the organization or the consulting bodies who are doing this really want to see change and what needs to change. Ideally, the planning is participatory. I know you've heard this from me from so many angles. This is a really good image of what things ideally should look like. Right? That this is a horizontal process, not a hierarchical one, that it's democratic so that there are votes and people have an active say. Decentralized, meaning that there's no one person or one entity making all the decisions. It's truly a collaboration. And in order for this to actually happen, it needs for everybody, particularly those who are coming into a community, to recognize that every individual at the table has an active subject in their own development. So it honors that capacity that we talked about last week in each individual at the table, regardless of their status or title or degree. Organization, program versus community priority is something that we will grapple with, that I'm sure you guys have heard from me enough, but I'm going to hammer home one more time. You can't start anywhere but where the key group wants to start and can engage at that time. There's several examples that I've given in the past. I'm just going to give one more example. Delavan Grider Community Center. This was a group of us from UB, and I was working with one of my committee members for my dissertation, and we went into the Delavan Grider neighborhood, which I'm somewhat familiar with because one of the entities that is now under Jericho Road, Vive, is there. It was for a long time the largest freestanding sanctuary for asylum seekers, and it's right in the heart of the Delavan Grider neighborhood, which is in the footprint of ECMC, if you are trying to locate that geographically in Buffalo. We went in, and there was a team that went up before us of students and some faculty who canvassed the neighborhood talking about the experiences and the priority needs around health in that neighborhood in particular. Demographically speaking, it is largely a community of those of minority status, relatively low income. It's considered a hotspot neighborhood, so you can have an idea of what that looks like. High crime, access to education is limited. We can go on and on and on. So we thought that maybe we needed to start with making healthy foods accessible, and we being the bigger body. I was along helping with the qualitative piece of this. Shocking, I know. So what shook out of this needs assessment that they did in canvassing the entire neighborhood was that the priority of the community was actually helping people get to existing things related to food, and really the priority was first and foremost getting people to appointments. There's a significant population of senior citizens in this neighborhood, in addition to young moms. And transportation has proven to be, and this was years ago now, but had proven to be a seriously challenging issue. So if we had stuck to our guns as the outsiders and decided that we needed to focus on food and bringing in almost like sustainable farming in the community, or a series of farmers markets, which there is one, by the way, in the footprint of ECMC, we would have missed the boat. We had to start where they needed to start, and they wanted to start and wanted to organize, and they very much did organize around transportation for senior citizens to get to medical appointments, and for young moms to do the same, as well as to pharmacy and groceries by pairing up with local churches in the vans that they have accessible to them. So just one concrete example of what it looks like and how wrong it could have gone if we stuck to what we thought they needed versus what they were telling us they wanted to start with. Not that they might not need access to healthy foods, but it wasn't their priority. So going back to put this all in context, we've talked so much thus far about all these surrounding factors that add up, that influence people's behaviors, ways to think about how someone's culture and norms intersect with their health behaviors. Now we're going to talk very squarely about the health communication and program planning cycle. What's before you now is the overall program planning cycle for public health, largely community health education. When you think about where we are in this circle, we're in strategy 2 when we're starting to talk about health communication and the program planning cycle. So communication planning is usually an integral part of a larger program plan. Sometimes we do see that there are separate, unique, freestanding health communication campaigns, but oftentimes health communication happens within the context of a larger program plan. So like I showed you last week, the circle that you see on your left is the overall program planning cycle. The circle that you see on the right is specific to health communication programming. So it's kind of an offshoot or a digging in of components 2 and 3 in the overall program planning cycle, where you're doing strategy development, marking out and articulating behavioral outcomes, creating approaches, solidifying your audiences, and then certainly in planning the intervention, message channeling, and the like. So if you look at the more specific corner, which we looked at briefly last week, it gets more headlong into focusing on the communication aspect, developing and pre-testing concepts, messages, and materials. Again, this would feed right back into the program planning cycle by spelling out this aspect of the program and how it fits within the bigger program in a given community or organization. So briefly, we're going to get into the key components of health communication planning. Overall goals sometimes can be fuzzy. Like we've talked about before, it's easy if we don't spell things out and keep our overall goal in hand to lose our path along the way, and we get sidetracked and follow all sorts of rabbit holes. Generally speaking, health communication goals are big and broad, and then we narrow down into more specific, like we do a research question, but focus on some of these key health interventions around morbidity, mortality, incidence, prevalence, and quality of life. Very familiar EPI terms. So creating that link again between epidemiology and what we know and find out there, and how we intervene on this level in terms of health communication, often in the context of a bigger program plan in a community. It's important in health communication planning to have specific outcome objectives related to communication, not just the overall program plan and the objectives that are put in place. If you think about this in program plan, you would have objectives related to the entire project. In this instance, you would have subset of objectives related to communication. So the results of the program might seek to have behavioral changes, social changes, organizational changes, but outcome objectives in any capacity, either over the whole program planning process, the overall goals of a larger program, and health communication, need to be SMART. They need to be time-bound and measurable. This is likely something you've heard before in other classes, so I won't belabor it, but it is something that people struggle with all the time, myself included, to make objectives clean and neat, specific, measurable, appropriate, realistic, and time-bound. I find that those of us who are, well, I cannot say it about me anymore, but those who are newer at this sometimes struggle with making them very realistic, and sometimes can hurt themselves in the long run because they have these very lofty goals or objectives, and they set themselves up for failure because what they have available to them does not meet what they can actually do. So if you go back to the overall image and look at the next step, this idea of situation and audience analysis is really critical. It's a needs assessment around communication, essentially. We touched on this last week very briefly, but just to go into a bit more depth here. Situation and audience analysis. So audience analysis is a part of a situation analysis, which we'll talk about in a second. But It's developed from a comprehensive review of the literature and ideally results from participatory research from the audience, such as interviews, focus groups, surveys, or a conglomeration thereof. And it helps to spell out and provide a map of sorts of all the factors that influence a specific health issue and its solutions. This is doing a situation analysis also helps us to define our key audiences, and ideally, in every way possible, should include key audiences and stakeholders. So oftentimes we go into a situation, we have a general idea of who we want to talk to and why. And that's often where we have to start. But then we should take those very surface level ideas, go to the community, get a true lay of the land by doing a situation analysis and an audience analysis, and have those very same people that we're talking about, a subset of them, join in the process to move forward and design the program from there. So communication objectives are evaluation parameters of the potential effectiveness of a communication effort. So if you go back to the bigger circle of the overall program, for instance, if we are trying to decrease the number of STIs in a particular community, and we're going to focus on adolescents, maybe Latina adolescents, because they unfortunately have higher rates of HIV infection currently, we need to look at our overall objectives, but we also need to look at the goals and objectives we set for health communication, and we need to be able to measure specifically how effective they are or are not, and so that we can tweak them if they're not aiding the overall program and decreasing the numbers. We need to think back about how our communication strategies are helping or hurting the overall effort. So basic questions: are we seeing the anticipated changes in behavior, knowledge, or skill? And how is our messages playing out with this particular audience? And you can do this in a number of ways. Validating the strategies is a really important piece, and that's often done by qualitative research. So you can go back to the same audience or a subset of the larger audience and ask them for feedback about the messaging. And you can then tweak the message as you move forward. It seems pretty silly, I would argue, if you just keep hammering home the same point that's not landing on the audience in a way that's helpful. Communication strategies which come out of the audience analysis and situation analysis, it's really very basically, and we're going to get into more about this next week, a description of the means by which we articulate outcome and communication objectives that will be met by the program. This really is, when you're writing this all out, if you're doing a proposal around these things, is very much in a research proposal, the procedures. Once you've established the messaging with the key audience and stakeholders, how are you going to roll it out? What channels? What's that look like? How is it going to go out in which different fashions, from print to radio to social media? It's those strategies that we're talking about here. So next is the actual plan. This is more like the methods section of research. A detailed description of audience-specific messages and materials, activities. This always includes a timeline, itemized budget, partnership plan. So different from the last piece where you're talking about the procedures, how are you going to get it out? This is very logistical. This is the nuts and bolts. This is providing examples of all the materials and activities you're going to do, when you're going to do them, and who's going to do them. Evaluation is always last, but very much not least, and hopefully is planned out from the very beginning. We've talked in many little bullet points already about how we're going to measure things. So as you're going along, to think through what you're going to do and how you're going to measure it from the very get-go makes this piece a lot easier. So it's a detailed description of overall outcomes, social, behavioral, organizational, of the actual program plan, including the specific communication evaluation outcomes, evaluation of the communication outcomes as well. This section always includes methods for data collection, analysis, reporting of findings, and costs associated with evaluation. It's not usually free, and organizations don't usually have the capacity in-house to evaluate what they're doing. So often they pull some consultants in, which sometimes gives us professors some money. Couple things to think about. I'm not going to read all these to you, but elements of an effective health communication program. It's really important, of course, to always start from the needs and preferences of the audiences, that you have involvement of the community and stakeholders at all points, that there's agreed upon expectations and outcomes with the stakeholders in the very community that you're serving. And whenever possible, which sometimes can be the biggest hindrance, is adequate funding and resources. There's certainly other aspects to this, but things to consider when you're putting something together. So we'll close from now, come back in a minute with another little piece of the puzzle.